Good morning, good evening, good afternoon, wherever you are. And thank you for joining us from so many countries. We have had a lot of registrations for this webinar today, so we're going to give you some time to log in whilst I am going through a number of pieces of information. Next slide, please, Jane. And next slide again, thank you. So today we are going to speak, the slide before perhaps. Today we're going to speak about dementia programs and solutions, long-term care and mental health. And I'm fortunate to be joined by an extraordinary panel that will share years and years, decades of knowledge with you today. I'm Paola Barbarino, I'm the CEO of Alzheimer's Disease International. And whilst you're all joining in, and before we start the webinar in earnest, I will launch a poll for you. And here is the poll, which should be coming in a minute, I hope. Yes, there you are. So we would really like to know which one of you are with us today. You can pick up from any of the categories that you can see on your screen. And if you don't see the category, please put it under other. And whilst we are waiting for all of you to join, if you could do that, it gives us a sense of who takes part in these webinars. Thank you very much. The poll will disappear from your screens in a few seconds. That's it. Next slide, please. And yes, so we got quite a few specialists today, specialist doctors, very interesting. A lot of people joining us. Well, we hope that you will all find that very interesting. Next slide, please. Okay, little bit about ADI. We were established in 1984. We are the umbrella organization of 105 Alzheimer and dementia associations around the world. And we are a non-state actor with the WHO. We represent our members of the WHO, the UN, OECD, and other global and regional bodies. But why we are doing this webinar today is that because of our particular work with the WHO and the number of things that we do together with them, and they kindly agreeing to tell us a little bit more about their programs in support for carers, in long-term care, and so on and so forth. ADI is also the promoter of World Alzheimer's Month, and we are the publisher of the World Alzheimer Report. I know a lot of you read every year. And our vision is prevention, care, and inclusion today, as we are all waiting and hoping for a therapy tomorrow, but it's not quite there quite yet, although almost there now. So next slide, please. Just a little reminder about the fact that everything that we do is free, and we are a charity. So if you would like to donate, we would be very grateful, and we're very grateful to all of you that have done so and allow us to keep everything we do free for everybody. Next slide, please. Whilst I'm speaking, a lot of you that are joining us, I can see now we are at 294 on my screen, are introducing themselves in the chat line. This is a very strong tradition of ADI. You're very welcome to introduce yourself, tell us which organization and which country you're coming from on the chat line. But during the webinar, when you will have questions, please use the Q&A box so that all the speakers can easily see which questions are being put to them. Please put your question in the Q&A box, and then we will pick up all questions at the end. Now, another slide I want to share with you today is about what is going to be the topic of the World Alzheimer Report 2024. The next World Alzheimer Report will be a follow-up to the survey that we did in 2019 that formed the baseline for stigma and attitude to dementias. The survey will be done this year as well. It will be online, but there are going to be options for offline replies as well. It's the same questionnaire that we did in 2019, but there are updated questions. It has already been translated in over 20 languages, and it will be eventually translated in 34. Our goal is to exceed the 70,000 responses. That's the amount of responses we had in 2019. It is not easy to get to 70,000 responses, and we do need all of your help. So we don't just need you to answer the questionnaires, although you should answer the questionnaire if you can, but you should also send it to family and friends. Right now, the situation is as follows. We have received 3,160 complete questionnaires, so there's still a long way to go, but the questionnaire will be open until May, so there's plenty of time. Currently, the countries on top are the Netherlands, with Mexico and Spain. So thank you very much to everybody that has been replied from the Netherlands, Mexico and Spain. But we need a lot more of you to reply. And in particular, we need replies from members of the public, people that are not aware about dementia. So that would be in particular very helpful this year. Next slide, please. This is about our conference in Krakow. So if you are interested in what we talk about and you're interested in all the area of the Global Dementia Action Plan, so diagnosis, dementia-friendly communities, treatment, care and support, risk reduction, data, research, and so on, please join us at the 26th Global Conference we're going to hold in Krakow from the 24th to the 26th of April this year. Now, all these QR codes that you're seeing on my slides allow you to go straight to the things that I am speaking about. Next slide, please. And it is my enormous pleasure to tell you that at the ADI Conference 2024, Her Majesty Queen Sofia of Spain and Her Royal Highness Princess Muna Al Hussein of Jordan will both attend our conference this year. This is an incredible honor, and we are delighted that they will. We hope that that will persuade more of you to come and join us in Krakow. Now, let me give you, next slide, please, Jane. Let me give you a little heads up about our next webinar. That will be a fireside chat. As you know, we got a separate series of webinars that are fireside chats. This one is going to be in care in the age of new treatments. Very interesting topic. Will feature Dale Goldhawk, our chair, interviewing Professor Sumi Banerjee of the University of Nottingham and Professor Dame Louise Robinson of Newcastle University. Together, they will be exploring what new biomarkers and treatments mean for those living with dementia and for their caregivers, and whether care and risk reduction is being sidelined by governments, healthcare systems, and the media. So these conversations are meant to be provocative, and I am hoping that you will be able to join us, and the link will be shared in the chat. Next slide, please. So, as I said earlier, we are a non-state actor in official relations with the WHO. As part of our joint work plan with the WHO, we are hosting this webinar to highlight WHO programs to support those living with dementia and carers. I should note that we're going to have a representative of the Mental Health and Substance Use Department, the Brain Health Unit, and also of the Aging Department. The webinar will feature case study where policy has been put into practice, and we really rely on you and your very interesting questions to have a lively conversation at the end. Whilst I was speaking, a lot more of you have joined. We are now at 354 online and more are joining. So thank you very much for joining us. And without further ado, I am now going to introduce our speakers. Next slide. So we're having with us Dr. Katrin Seeher, who is the Technical Officer in the Department of Health and Substance Use at the WHO. We are going to have then, sorry, my slide has gone blurry. Dr. Menan Rabie, the head of something that sounds quite complicated, GSMHAT, but actually means Secretary General of Mental Health and Addiction Treatment at the Ministry of Health and Population in Egypt. Then we are going to have Dr. Yuka Sumi, who is the Medical Officer for Integrated Care for Older People, ICOPE. Hyobum Jang, the Medical Officer for Long-Term Care in the Aging and Health Unit. And last but not least, Jenny Chin Hansen, who is the former CEO of the American Geriatric Society. So thank you very much for all of you that are joining us. Whilst I was speaking, even more people are coming in. Very welcome to everyone. I remind you, please introduce yourself in the chat if you would like to, and tell us which organization are you from and which country are you from. And please put your question in the Q&A for the speakers. We'll pick them up at the end of the webinar. And now, without further ado, Katrin, the floor is yours.
Thank you so much, Paola. Thank you, everyone, for joining. It's a great pleasure to be part of this webinar organized by ADI. We at WHO are immensely grateful to share some of the efforts that we across various teams in the organization have been doing, also in partnership with our member states. You will hear from other speakers and our other civil society partners and academic partners on how we're trying to support people living with dementia and their carers. Next slide, please. So what I'm going to talk about is one of the flagship programs that we've been running at WHO in the area of mental, neurological, and substance use disorders, but you'll hear from other colleagues around other areas. If we can go to the next slide. So everything that you will hear today is actually in support of the Global Action Plan on the public health response to dementia, and really in support of its vision, which dreams to one day prevent dementia entirely, and that people living with dementia and their carers can live well and receive the care and support that they need, with the goal to really improve the lives of people living with dementia, their carers and families. The action plan has, as you probably all heard by now, 7 strategic action areas, and 2 of them are of particularly importance for the webinar today. That is action area 4, which deals with dementia diagnosis, treatment, and care, and action area 5, which is on caregiver support. Next slide, please. But as I mentioned, I will focus today on mhGAP, or the Mental Health Gap Action Program for long. So that came into effect a long time before we even had the Dementia Action Plan. And it is WHO's core work in the area of mental, neurological, and substance use disorders. And it's basically now a series of updated guidelines over time, with the main focus on providing high quality and timely evidence-based guidance to specifically non-specialist health workers in low and middle income countries. It's for 10 priority conditions, and dementia has been one of them from the outset. We've just last year in November released the update. It's now the 3rd edition of the mhGAP guidelines, and that includes 90 previously included recommendations that were carried forward and 48 new and updated recommendations. And over the next few minutes, I'll show you what the dementia module particularly looks like. Can we go to the next slide? Thank you. So this is in a snapshot, the dementia module. It's only one of 11 included in the updated guidelines. And we have 11 so-called PICOs. So those are the broader research questions that the guideline tries to address. These 11 areas or questions fall into 5 areas that you see here on the slide. So there are recommendations around dementia diagnosis, around pharmacological treatment or medicines, non-pharmacological treatment. That's an area that we've expanded significantly since the last update. One area on caregiver support, and the last one on nutrition. Now, some of these recommendations, they were carried forward by the guideline development group. They are still valid compared to the previous version that was released in 2015. But 16 recommendations are actually new. And I'm going to show you on the next slide what they are. But before we do this, I want to give a big shout out. No, you can stay, Jane, thank you. I want to give a big shout out to Professor Yunhee John in Sydney University and her team, who helped us in actually doing the very comprehensive evidence synthesis that was required to come up with these new recommendations. So what's new in that guideline update that was released in November? We now have a lot more evidence in the area of non-pharmacological interventions and support. So the first recommendations is actually people living with dementia should be offered physical activity, ideally delivered 3 to 4 times per week for 30 to 45 minutes for more than 12 weeks. And the other recommendation to support people living with dementia is that non-pharmacological interventions such as cognitive behavioral therapy, cognitive stimulation therapy, or cognitive training should be considered for people living with dementia, depending on availability. And the other area or big area of update, because there's been a lot more evidence released since the earlier version, was on carer support. And here the guidelines now suggest or recommend that psychosocial interventions, for instance, mindfulness, multi-component or psychoeducation, psychotherapy or counseling should be offered to people, to carers of people living with dementia. And respite care should be considered if it's available in the context. And then another additional new recommendation is that if a caregiver experiences depression or anxiety, then they should be assessed and treated in line with other mhGAP recommendations for those conditions. Next slide. Now, as you probably all know, just having guidelines doesn't mean that they are implemented or adhered to on the ground. So mhGAP has a long tradition of actually coming with derivative products or with additional tools and guides to help implementers on the ground, but also clinicians and other stakeholders to translate those recommendations into actions. So mhGAP has an intervention guide that actually lays out decision tree that maps for clinicians exactly what they should be doing for each of the priority conditions. It has an app, it has training material, an operations manual, and it also comes with support for community workers. Interestingly, mhGAP also contributed to the development of ICOPE, which many of you may have heard. And that's the online training that WHO has for supporting caregivers of people living with dementia. So we're really trying to make those recommendations more livable and implementable. Next slide. But that's not all. We also want to hear from you. And we've created this GDO, or Global Dementia Observatory Knowledge Exchange platform. So if there are any tools or trainings or materials that you have developed in your contexts that would actually help diagnose, treat, or support people with dementia or their carers, please consider submitting it for peer review to our platform. You see the link here, globaldementia.org, and you can see what others have already shared, and we're making this a mutual exchange of good practices around the world, all in support of our Global Dementia Action Plan. And with this very brief overview, I'll hand back to Paola.
Thank you very much, Katrin. There we go. A fantastic presentation. I think Katrin couldn't have made mhGAP, which is an extraordinarily complex and thorough and incredibly well-researched amount and set of tools, recommendation, etc. She couldn't have made it easier for people to understand. I am maneuvering my Zoom at the moment. Yes, it is working. For some reason, I become very small when people stop speaking. So, Katrin, thank you so much for this extremely speedy summary. And I am hoping that we are going to have a lot of questions. Now, can I remind you, please, the questions in the Q&A box and your introductions and who you are and organization you come in with in the chat. I've seen quite a lot of people already asking for connections to other people. You're very welcome to do that. But if you don't manage to find connections after the webinar, you're also always welcome to write to ADI. And we'll put you in touch with the member of ADI relevant for that country. Now, without further ado, we are going to go into our second presentation, and it's a joy to introduce Professor Menan Rabie, Technical Officer, Secretary General of the Mental Health and Addiction Treatment Unit at the Ministry of Health and Population in Egypt. Welcome, Professor Rabie. Thank you for being with us today. I am going now to hand over the floor to you for your particular focus on your country perspective. Thank you so much.
Thank you, Dr. Paola. How are you? I hope you're all fine, and I hope you're enjoying this marvelous webinar. I think it's a very interesting topic to be covered by this huge amount of experts and professors, and I'm really enjoying being there with you, being here with you. Excuse me, I have two presentations, but they are very short. One of them is about the whole problem of old age psychiatry, and the other one is about the mhGAP per se. About the activities of the old age psychiatry department in the General Secretariat of Mental Health, we sense that the populations around the world are rapidly aging. Aging presents both challenges and opportunities. Whenever we mention geriatric psychiatry, dementia is the first disorder that crosses our minds. There are many types of dementia, but the most common one is the Alzheimer disease. Living well with dementia is the aim of dementia care. The National Survey for the Psychiatric and Substance Use Disorders 2023, this is a very recent research which showed a lot of info about especially the old age, and proudly I can say that this is the first psychiatric screening tool to assess the old age for both psychiatric disorders and cognitive disorders. During this, we discovered that 20.5% of old age groups suffered from major neurocognitive impairment. This is a big number. And 27.6% suffered from mild cognitive impairment. So cognitive impairment is a real challenge in our current days. Actually, they are also suffering from depression. They are also suffering from some anxiety problems, some problems of the daily living activities. So this population are really in need for services. We are trying now to start a deal with our dear friends in the WHO to start the strategy and the action plan, which we already discussed in Qatar, the last meeting. And I think this is a very important point to start the true action plan in Egypt, and especially from the Ministry of Health and Population. We care in this plan about raising the awareness and about the diminution of a reduction of the dementia risk, and especially in the high-risk groups, and of course to improve the therapeutic measures. And currently we are thinking very seriously about starting daycare units for patients with old age, either with dementia or with other psychiatric disorders, and this will be starting in 3 of our big hospitals in Egypt. The daycare facilities will provide services to people with mild to moderate dementia, and this facilities may provide a place where family members who care for an older person full-time can take the older person and get a break from caregiving. I think this will be a breakthrough in our services in Egypt. As a matter of fact, the training courses are ongoing. They actually never stop. The old age department conducted many training courses up to maybe every month or so for psychiatrists, nurses, psychologists, and social workers from the different mental health hospitals. Actually, we are having 24 mental health hospitals and centers all over Egypt. And this is a very good coverage. They cover about 17 governorates of the 27 governorates. We had a very good campaign during the last book fair. The book fair was in January, last January, and we had a very nice leaflets for awareness, for raising the awareness of the population. And actually, people went to ask about it, how to deal with a patient with cognitive deficiency, how to deal with a patient with old age depression, and that was really very. It was asked for it. People asked for it. Just a minute. Another important issue is that we are trying to cooperate now with the primary care facilities, because the primary care facilities are the nearest to the population, nearest to the person, especially in the poor areas and in the rural areas. We are preparing a manual for them, a special manual for the old age about how to assess for psychiatric disorders, especially for it's for non-psychiatrists, but they have to be medical personnel, either nurse or doctor or maybe pharmacist or social worker, somebody inside the primary care facility, and they can detect easily if there is a problem with the old age, and they can refer this patient to a tertiary care facility so he gets the best care possible. We are trying to conduct campaigns for raising awareness, especially with the religious facilities in our country, with the church and with the Al-Azhar, and they are very cooperative, and they are actually easily getting inside the populations better than the doctors, of course. And we are trying to collaborate with the Inner Wheel Club. We are seeing centers with them. Maybe these centers in the future, in the near future, will be a very good old age centers. Also, we try to get into the social media with a lot of informative mini videos, so that patients and the general population gets more info about how to diagnose Alzheimer, how to deal with a patient with Alzheimer, how to help a patient with Alzheimer, how to prevent problems in such patients. This is, and of course, it was very good to receive Paola, Dr. Paola, in our last conference. It was the Global PHCDC, which was the Population Health and Development Conference. It was a very good one, and we're waiting for you for the other one this year. And actually, it was very nice to be a plenary lecturer in such an important conference, and we really enjoyed it. Thank you very much, Dr. Paola. As for the mhGAP plan, actually, we are working with the mhGAP since 2017, but it went into action actually in 2019. We started to cover many governorates every year, and we are working maybe 2 or 3 governorates every year, and it's almost covering more than half of Egypt. But of course, it will be reinforced more if we get inside the primary healthcare facilities, and we can remove the stigma of the population about dealing with psychiatric patients or Alzheimer patients. And I think this will be a real jump to the future. We also have a platform, which is, I think it's very important, because they can help people inside their homes. We have the mental health platform, and in this platform, we have many services. One of them is some information about the problems, psychiatric problems, especially dementia. And of course, there is also the an area to self-assess, a self-assessment tool. And we have also video calls with therapists. It can be booked online so that patient or his family can get into a real conversation with a therapist. This is, I think, a very important tool to help population all over Egypt to get the treatment they need. Of course, the real challenge in this is that the medications are not easily prescribed through the online service. Also, we have a helpline. It's a short number, 5 numbers telephone call, and it's for free. And everybody can get, and the platform also is free. Everybody can get into a therapist or a social worker to help him either know where the service is or to get the therapy session on by the phone, if it's possible, of course, on the clinical level. Actually, we need to let everybody knows that we are trying to improve the services, especially for this population, because this population is actually maybe not having the exact amount of service they deserve. And we happily are announcing that we have a presidential initiative in Egypt for the old age psychiatric care, and this is important and very effective as regards reaching population.
Thank you, Dr. Rabie. I have to ask you to wrap up.
Thank you. I finished. Thank you very much.
Thank you very much. And it was my utmost pleasure to be with you in Egypt and being able to see the amazing amount of things, especially the way that you're reaching really difficult to reach area. I think it's an example for everybody. I've seen that there is a lot of questions for you in the chat line. Can I ask people please to put your questions in the Q&A rather than the chat line, because otherwise we lose them. And we will pick up all those questions. So stay with us. We've got 1 hour and 15 for this webinar today. Now, because there is a lot more participants now that we had at the beginning, can I ask Jane and Megan, please, to rerun the poll? We have added government representative because we know there's a lot of you who are government representatives today. So could you please refill the poll now that it's online again? We'll leave it there for about another 10 seconds. So there's over 420 of you online. We really need to know who is online because that helps us in future make sure which category we don't have enough listeners of, and we can increase that category. So another 10 seconds and that's it. The poll is going to flash on your screen again. Brilliant. Thank you very much. I can ask a member of ADI's team, please, to take a picture of this so that we can comment on it later. Thank you. And now we will close the poll. Now, thank you very much to everybody. I'm going to reset the timer and give the floor now to Yuka Sumi. Yuka is the medical officer of WHO Aging and Health Unit. I think it was Yuka speaking first, but I see that Hyobum is speaking first. I've got Hyobum bio on the screen. Jane and Megan, maybe you want to put Yuma? Anyway, so Dr. Yuka Sumi is the medical officer for WHO Aging and Health Unit, Department of Maternal, Newborn, Child and Adolescent Health and Aging in the Universal Health Coverage Life course. Yuka has prepared an incredibly engaging presentation. I can see that all of you are terribly engaged today. So thank you for staying with us. Yuka, the floor is yours.
Thank you so much, Paola, and thank you so much for the support by ADI disseminating this is important initiative. And also, I would like to acknowledge the collaboration with the Brain Health Unit. And everybody understands that many people with dementia are older people, but the older people might have more than dementia and different issues, as Dr. Rabie mentioned. So happy to share my slide. Okay. So today I'm going to talk about implementing care for healthy aging, and especially around integrated care for older people, ICOPE approach WHO is promoting. So many people may know we define healthy aging as a process of developing and maintaining the functional ability that enables well-being in older age. Regardless of the presence or absence of diseases, we can maintain the function so that we can continue whatever we like or we have reason to value. And functional ability is combination of intrinsic capacity. So whatever we have under the skin and the environment the person lives in, and how people interact with their environment and intrinsic capacity. And environments include housing, assisted products, transportation, social facilities. As you can see in the picture on the left side, or the person might have a mobility issue, which is their intrinsic capacity, but providing walkers and safe street with the roof, actually older people can enjoy shopping, going to see friends and family. As on the right side, as you probably everybody knows, hearing loss and dementia are closely related. So older woman in the picture might have a hearing loss, but providing hearing aids, actually she can communicate and participate in the community. So this is actually already 4th year of the UN Decade of Healthy Aging. That is a global collaboration to bring together diverse sectors and stakeholders to improve the lives of older people, their families, and the communities where they live. So it's promoting aging in place. We have 4 action areas, including combating ageism, supporting age-friendly environments, and deliver person-centered integrated care and primary health services, access to long-term care. My colleague Hyobum Jang will talk about long-term care. Today, my presentation, I'm focusing on the 3rd action area, deliver person-centered integrated care and primary health services responsive to older people. So what do we mean by integrated care for older people? That is the continuum care that will help to reorient health and social services towards a more person-centered and coordinated care that supports optimizing intrinsic capacity and functional ability for older people. So key point here is coordination and continuum and person-centered. If you look at the framework on the right side, older person always at the center with the aim of maximizing intrinsic capacity and functional ability. And then service needs to be organized, and then system needs to be strengthened. So all the micro level, meso level, macro level needs to be worked on. So this is kind of the thematic case example. For example, 75 years of the women with hypertension. You can see the red line and blue line, which is intrinsic capacity and functional ability. On the x-axis, that is a chronological time, but I didn't put any age number because every older person is different. On the bottom, we listed a different care component, including promotion and prevention of decline of intrinsic capacity, management of underlying health conditions, in this case, hypertension, care coordination, and social support. Older person might have a pneumonia that requires acute care, but at the same time, this is really important to provide intervention to prevent decline of intrinsic capacity, including exercise, nutrition, cognitive stimulation. Older person might have a hip fracture by fall afterwards that requires acute care rehabilitation walking aid as an assisted product. Later on, this woman might develop the cognitive decline that might require the home modification in addition to acute care and rehabilitation. And then finally, at the later stage, if the older person has a significant loss of capacity, having a dementia, having pneumonia, having delirium, the palliative care, assistive care, and caregiver support, long-term care that include home visit by health and care workers might be needed. So in this case example, I wanted to highlight is continuum care, regardless of the intrinsic capacity level or functional ability level. We can provide different services to respond to the diverse needs of older people. Just to bring back to the why primary health care is important. As you can see in the different photos from Cambodia, Botswana, Kuwait, and Ukraine, although every health system and service delivery are different, setting, workforce, financing, referral care pathway, primary health care is the key for the universal health coverage. That means providing essential care services without financial burden when needed, where they need. So we have an intervention recommended to manage declining intrinsic capacity. As you can see, different components or different domains of intrinsic capacities are included, including limited mobility, malnutrition, visual impairment, hearing loss, cognitive decline, depressive symptoms. WHO is recommending to assess, screen, manage these different domains of intrinsic capacity in the integrated way, not by silo, because that, for example, mobility related to the malnutrition, cognitive decline related to the hearing loss, as well as the depressive symptoms. So how can we holistically assess the needs of older people and to provide management? Other interventions include urinary incontinence, preventing falls, supporting caregivers. And all the intervention is actually closely linked to the mhGAP intervention guide, as WHO to have one narrative to manage different conditions. So just to give you an idea what we are learning from the different member states. In 2021, we developed our findings from the ICOPE ready phase. We featured 4 case studies. But now there are many different countries interested in implementing or piloting implementing ICOPE approach. What we have learned as opportunities, we got the really good positive feedback from health and care workers across member states, great interest and commitment to provide integrated care for older people. Positive feedback from older people. Many older people say, for the first time, my concerns are heard, not only about disease diagnosis, but about capacity and ability so that they can enjoy what they like. And the older person's engagement has been shown to be critical across all steps of the ICOPE approach and its care pathways. As I showed in the photos, there are very different diverse care settings, but ICOPE approach is feasible and adaptable, but key is local co-design, including multi-stakeholder engagement and partnership. And we can really engage and empower the community, town hall, post office, community leaders. As Dr. Rabie mentioned about religious groups, that's also really important entry point to implement implement ICOPE approach. Finally, there are many resources available on WHO website. We actually have a case studies on the progress report, and the ADI activities are featured in the case report. I really recommend for you to look at this website. Thank you very much for your attention.
Thank you very much, Yuka. That was a fantastic presentation. A lot of people who will have asked the questions around certain areas, like, for example, visual impairment, sensory issues, will have seen that Yuka has already answered them. This is a complex presentation and a complex webinar because the WHO is working on many fronts. So we wanted you to have a sense that, this is not an organization that is working in isolation. However, many of these areas are incredibly specialized. So there is teams of people that are tackling the various issues, but they're all talking together. And we at ADI are fortunate enough to know what's happening. So we wanted you to have that sense of complexity but also of the fact that there's a lot of people that really do understand person-centered care and doing their utmost best to make sure that it's dealt with properly. Now, I've got a couple of points I'd like to make to everybody attending. We are still well over 420 people. Please write your questions in the Q&A and please introduce yourself in the chat. And also bear in mind that we are going to answer questions at the end, so stay with us until the end. And now I'm going to cede the floor to Hyobum Jang. Dr. Hyobum Jang is Medical Officer for Long-Term Care in the Aging and Health Unit section of the WHO. And he is going to continue deepening our understanding in all the activities that the unit is taking at the moment. So Hyobum, the floor is yours. It's a delight to have you with us.
Thank you. Thank you so much, Paola. And thank you for all the participants, attendants who are listening to our presentation. This is a great opportunity to be connected with you and then hearing and learning and sharing all the knowledge and lessons within all the communities around the world. So thank you for your attention. And yeah, my colleague Yuka has already introduced the concept of Decade of Healthy Aging, which is the main framework that we are working on. And she already mentioned we have a particular 2 action areas on interim care and long-term care. So I will particularly speak about long-term care. Is the slides going on? Sorry, Jane? Thank you. Yeah. So yeah, we can go to the next. Thank you. So we know the situation that around the world, and then also not only in the high-income countries, but also in low and middle-income countries, population is aging around the world. As people age, they have multiple health and disease conditions, and which includes dementia. So people living with dementia would be one of the most significant. They take a significant portion of the people who need care from others, which we define long-term care. We define long-term care not only in the residential institutional nursing homes, but across all the different care settings, people who need care from others, like carers and care workers, to maintain their function while they are having a significant loss of interest capacity, as my colleague Yuka mentioned. But countries are not really well prepared to provide long-term care. Governments may not think of long-term care as a responsibility to provide to people, like healthcare, and health ministries may not consider long-term care as their responsibility, as well as health workers. So WHO, as of one of the first steps, WHO published this framework of long-term care, which we call Framework for Countries to Achieve an Intercontinental Long-Term Care. So this framework is a tool and framework which benchmark health system framework of WHO to help countries, governments, and ministries understand long-term care can be assessed and then implemented within their health and care systems. Next, please. In this long-term care framework, we have included some tools, including checklists of core elements and key action points to establish and implement long-term care in countries. So we have used this checklist to support countries to assess their national context and situation as a part of developing the care system for all the people, of course, including people with dementia. Next, please. Following the publication of long-term care framework, we are now about to publish so-called package of long-term care interventions for universal health coverage. So the objective is to support countries to design and establish and expand long-term care systems and services, which could be part of the universal health coverage by providing these recommended interventions and also advising on facilitating factors. So this package already provides a list of long-term care interventions so that they can consider to integrate within their health and social sectors. And one particular emphasis is that this package addresses the role of unpaid informal family carers, not as both care providers and receivers. Next, please. Just briefly to mention the content of this long-term care package, which is to be published. So we are now seeing some key essence of the unpublished WHO publication, but which it would be helpful for your understanding. So we have listed some essential interventions to address various needs of people, older people and carers. You can see there are three types of long-term care interventions, from healthcare, palliative care, and social care and support needs. It is also important to see that these interventions is framed to be provided by different actors in the care network, not only professional health workers, doctors, or nurses, but all the people related to care provision in the community, including partners, care partners, and caregivers themselves. And also you can see those long-term care is provided across various care continuum and care settings, not only long-term care facilities or nursing homes, but also different settings like a daycare or the assisted living facilities in the community settings, including their home to promote aging in place. And there are also some facilitating factors, which are like principles or concepts to integrate the long-term care inside the person-centered integrated care process, which also my colleague Yuka mentioned. And it doesn't provide only the list of interventions to be integrated, but also we provide some advice and considerations for the implementation of this package, how the long-term care intervention services can be integrated in the systems and already existing service provision. And inside it, as Yuka and other colleagues mentioned, we highlighted the need to engage older people and carers in this process, hearing from their voices, hearing from their experiences, and reflect their opinions and decision-making and service provision. Next, please. Oh, previous one, please. Sorry. One more thing. So I was very happy to see Katrin mention carer support as one of the important components of the Global Dementia Action Plan. Inside this long-term care package, we again highlighted carers for their needs and then their support to say that not only all the people's needs, but also carers' needs should be assessed and addressed by this integrated care of long-term care for all the people. And also the education and training should be not only provided to professional health or care workers, but also these informal carers and family and unpaid carers who are still having a lot of work to provide to their families without proper support. Next, please. We still have a lot of things to do. We have many opportunities and areas to fill. So as we all know, we are facing the population aging, and then there are a lot of increased amount of unmet care needs for older people living with dementia and their carers. Countries and governments, regions, they see this increasing and emerging demand, and they are quickly moving forward to act on developing national policies, strategies, programs, and guidelines to foster healthy aging and provide long-term care. So the reorientation of care from just focusing on healthcare, but to broader health and social care, including long-term care, they will support social economic growth and promotion. By this, making services more responsive to needs and priorities, but also respecting the rights and dignity of older people and people living with dementia. And on the ground, whatever we call this aging program, long-term care program, or dementia program, we know that those programs are targeting the similar population who need care from others. So we need to really advocate this integrate person-centered care should be conducted across the care continuum, across the different settings. And again, the need for the focus on carers, while there are many programs are supporting the needs of informal carers, there should be more comprehensive government-led and government accountable approaches, and we are mandated to provide package of resources to foster training, capacity building, and education support for all the actors and carers. So around the world, we know that there are so many important and already successful programs and initiatives around the world, which includes the next speaker's example from the United States. So we are really looking forward to hearing from all of you from around the world about your exciting and interesting and also lessons from the field. And then we, the WHO, will work with you to develop your experience into technical guidance and to support countries and people on the ground. Thank you so much for this opportunity again, and it's over to you. Thank you.
Thank you very much. In particular, I'd like to draw the attention of all that are participating to the incredibly complex and rich slide that Hyobum presented to us about opportunities. As you know, at ADI, we've been now advocating for a long time for the creation of national plan for dementia. This is in great part due to the WHO emphasis also on creating a global dementia action plan that we have been advocating for a long time. Plans are still extraordinarily important, and the more you hear this presentation, the more you understand why. The complexity around long-term care, the complexities around mental health issues are enormous, and we need to be organized. There is a lot of questions in the Q&A also around other elements, like, for example, timely diagnosis. Hopefully we'll be able to take them on at the end of the webinar. Now, it's my pleasure to introduce to you Jenny Chin Hansen, who is the former CEO of the American Geriatric Society. Jenny, the floor is yours.
Well, thank you very much, and thank you for the privilege of being here with ADI, and a particular thanks to Dr. Jang, whom I met a couple of years ago here in the United States, and has invited me here. So I think our audience has heard about the broad system of the issue of how dementia affects us from a demographic perspective, policy, programmatic, family, and individual. So the on-the-ground lessons, I think I heard the phrase come from Dr. Jang, is an example of one of the programs that we have here in the United States. I was actually connected with this program literally 43 years ago when we first started. And over the course of time, I came in as a researcher, ended up running operations and becoming the CEO of this original PACE program called Unlock Senior Health Services in San Francisco. Fast forward, we were finding some studies on the ground with this model that I'll go into, but we then included the test of other sites around the US. And so we replicated the operating model in San Francisco with some of the outcomes that we found in terms of quality, in terms of outcomes for clinical performance, satisfaction, and costs. And so this model started locally in a neighborhood in San Francisco. And you'll see in a couple of minutes, it has moved to a national spread into federal US policy with our Medicare program. And so I was with the program for nearly 25 years, from a researcher to the CEO to helping pass federal legislation to make this possible in the country. I put on this slide in particular, and the last slide will give you the website and the connection again, that this now is a national collection of all the organizations in the US. And this is a national association of this particular program called PACE. Next slide, please. The philosophy behind the program is the fact that, as we were talking about, many residential homes or nursing homes, as we call them here, are the option that we had 45 years ago. Instead, we know that most people want to stay in their own familiar home, have choice and voice, and to be able to do their best in terms of maintaining their abilities, physical, social, and cognitive. And therein comes the whole area of dementia that is incorporated. So this is not a program that focuses solely on dementia. This goes back to the concept of a person-centered home. And the fact that dementia may be, frankly, one of the comorbidities that people have. And one of the things that I wanted to share with you, that this humble beginning 43 years ago is now called PACE in the United States now. The government does pay for it under our Medicare benefit. There are 32 states out of our 50 states that have this program, including Washington, D.C. So still, even though people are in the United States certified to be qualified to be in a nursing home facility, 95% of the members are still in the community. Next slide, please. So many of the services that have been spoken about by the previous speakers are included in this PACE model. You'll see it from nursing services, the physical and occupational therapy, also recreational therapy. As we know in dementia, the sense of socialization is important. Meals are afforded as needed, nutritional counseling, the social work services, physician care. We have physicians and nurse practitioners and physician assistants. We provide care not only in a day center, but also in home care. And personal care, this is where our direct care workers or our carers provide care in the home and in the center. All medications are covered. We have master's level social work services. And what was spoken about before includes audiology. So because in dementia, we know from our studies that without hearing well, that can add to the clinical issues of dementia. We provide dental care, which is oftentimes not thought about, but so important to a person's well-being. Eyeglasses, foot care, speech therapy, and even for the family carers, there's the opportunity to have a respite. And so while people are staying at home, when they have to go to the hospital, or even if they do go to a nursing home program, they remain, quotes, part of the family of this program so long they choose to be. Next, please. I apologize for this picture. Usually there are live pop-ups in terms of activities, but this is a program that depends on care coordination as well as interdisciplinary teams. So the various services that are cited in the previous slide come together in these meetings. So we may have a direct care worker and a physician sitting at the same table. So it's a program that's meant to be personalized and focused on a whole coordination. So you don't have to go to different entities for these services. You basically have a medical home and a social home. And so these are the services. We provide transportation back and forth from their home. And we make sure that their medications are delivered to them as well. And this gives you a sense of the teamwork that's involved. So the family member and the person who has not only dementia, perhaps, but all the other comorbidities in terms of congestive heart failure, COPD, with different conditions. So it's not only a diagnosis, this is a holistic care. Next slide, please. And in particular, I wanted to make sure that you saw that there are people who are resources there, because dementia, I know, of course, is the focus of this, but we do it person-centered in that they have other physical conditions. And so we treat the whole individual with these services. And in particular, there are two lead organizations that I've cited here that have done some extensive work for the past decade on having behavioral health and dementia come together. And there are 9 programs in the country right now that really have a particular focus. And there is a toolkit that's available for people who are members. So when I cite these programs, I wanted to make sure that our audience here knows that there are tools that have been developed. And since the PACE program went into federal effect 26 years ago, there are many people scattered in the 32 states, as well as in Washington, D.C. And then the final slide, please. I wanted to make sure that you had the names of individuals, and the main resource is the last item, called the National PACE Association. And the website is there for you to be able to see much more detail what these programs encompass. And the fact that I'd like to end with the last comment that during COVID and the pandemic, the elders who were in this program actually had less infection rate. They were able to create different types of services that were more remote. And our performance as a collective program in the United States showed that our elders' longevity, infection rate, and the fact that their family members were able to be a part of the team were a part of what PACE has done. And there is an article that just came out about a month ago that you can receive through the National PACE Association, or I'm happy to share that with our organizer to show the study of the impact during the pandemic and how the elders who were enrolled here fared much better than the standard approach. So I'm delighted to have a chance to tell you, the on-the-ground example of something that we've had to have here in the United States for decades. And I am proud that what we started in the community became national policy with payment policy that went with it. Thank you.
Thank you very much, Jenny, for a very enlightening presentation, and also for the practical way in which all of this can then be translated in things that work on the ground. Now, we don't have a lot of time for questions. We have a lot of questions. So I'm going to go straight into questions. And I'm going to ask questions to each of the speakers individually. Katrin, I start with you. There are 2 questions that you probably can answer together. Interesting update on the mhGAP guidelines. I see the recommendation for cholinesterase inhibitors like donepezil and memantine. Are these drugs included in the WHO essential medicine list? How can we ensure they are available and accessible in all countries? The second question is from Anders Vimo. Katrin, mhGAP medicines, although the new disease-modifying Alzheimer's drugs are extremely expensive and not available in most countries, has WHO so far discussed any strategy about them? So these 2 are for you. I leave you with them.
Thank you, Paola. And yes, I'll try to answer them together. A short answer to are cholinesterase inhibitors and memantine on the essential medicine list? No, they've been submitted for the last review, and due to the still very limited or low quality of the evidence, they were not included in the last update. In the PDF slides of my presentation, you will see one additional slide that I didn't show you during the meeting that has the full recommendations for each of the included ones in mhGAP. And there you see that the problem for medicines often, as it stands, is that the quality or of the evidence remains low or very low. This is linked to the problem that we're also having with new disease-modifying treatment and the question that Anders has raised. And that comes back to one issue that causes me personally a lot of grief, and that is how we can measure better actual outcomes, outcomes that matter to patients, outcomes that are relevant clinically, and this is we're monitoring very carefully at WHO the new arising evidence for disease-modifying treatments. But at this stage, we feel that we're not there to make any recommendations, and certainly didn't have the evidence to include disease-modifying treatments in the update of mhGAP. But yeah, we'll continue to watch the evidence and the science very closely on this. It's exciting times.
Thank you, Katrin. I hope this also answers a number of questions that are about new treatments. Just so that everybody knows, we at ADI presented the case for making cholinesterase inhibitors work on the essential medicine list. It has to be a charity like us that does it, and we did it, and we had a lot of support from Katrin and her team. But these things are very complex to pass through. We'll probably try again. But as Katrin say, it is about having the evidence. So we need to have more scientists working more on the evidence. So this has to be a concerted effort. Now, very briefly, please, the next answer. There is a question from Amina Sorafan for Professor Rabie. Can you briefly tell me which study you did among the elderly to find the prevalence of the cognitive impairment and which tools were used? Thank you.
Yes, actually, in Egypt, we conducted a survey, a community survey last year, 2023, and we used the MOHP for the cognitive impairment issues and a screening tool, general health questionnaire. That was conducted in Egypt through the research unit in the General Secretariat of Mental Health and Addiction Treatment in 27 governorates of Egypt.
Thank you, Professor Rabie. There's also a specific question about the involvement of Al-Azhar and the impacts at the community level, and how can they access this information? So perhaps you can do that separately, unless you want to say it quickly now.
I just sent my WhatsApp number so everybody can get the info they need.
That is so kind of you. The next question now, I'm going to put that in particular to Yuka. There is a question here from John Zeisel. He says that from the World Alzheimer Report 2020, which John was one of the compiler of, the way the physical environment is designed can reduce symptomatic challenges. Why does WHO not include these evidence-based guidelines in what WHO defines as non-pharmacological treatment? Now, the work of John, in particular, Yuka, was around the environmental, the space around us. So building new care home, building new hospitals. I'm sure you have done some work around that. Would you like to take the floor on this one?
Sure. So in terms of the preventing falls, actually physical environment modification is part of the recommended intervention. So it's more like a closer environment. But in terms of the bigger approach, in terms of the community, age-friendly primary healthcare services, age-friendly environment, we actually have an initiative under the UN Decade of Healthy Aging specifically focused on the environment, because environment matters a lot for the older people. Thank you.
Thank you very much, Yuka. Such an important one. Hyobum, the next one is for you. There is a question around early diagnosis. I would prefer to focus on timely diagnosis, perhaps. At ADI, we like to speak about timely diagnosis, but it's an issue about the fact that we talk a lot about aging, but actually dementia as a cognitive impaired disorder hits a lot of young people. And we all know that, especially those of us who have been in Japan where early and better diagnostic techniques are bringing out a lot of people in their 30s and 40s, unfortunately, that develop the disease. Hyobum, would you like to say something more about that?
Thank you, Paola. So as Yuka already showed during our presentation, we can think as a continuum of care throughout the life course of biological aging, not only thinking of separated or late diagnosis care or long-term care for those who have already significantly lost their capacity and then who needs more substantial amount of care. If you can approach as a life course approach that already starts from the first half or early, later half of your life, and if the interventions are provided earlier, then of course it is better for preventing the loss of their the capacity and function throughout their life, but also helpful to address the needs of people as well as alleviating the burden of care for the later stages. So that is very relevant point, I think. Thank you.
Thank you very much. That's such a good reply to that question. And very briefly, we don't have time anymore, but I really want to take this one. Very interesting question for Jenny. With the PACE model in the USA, what were your real challenges?
It was the speed of growth. It's a very much more comprehensive system than typically has been offered historically. And so you have to coordinate all those services that you saw on the list. And there are specific requirements because it's to develop a center, to make contracts with hospitals, transportation system, hire people. It was slow growing in the early days. I mentioned that the legislation in the US passed 26 years ago. The last 5 years, we have seen a growth really start to bloom. We know that private investors have joined in, and when you have a capital market that has joined, the growth is now much faster.
Thank you so much. And with that, I'm about to close this webinar. I want to remind you of two things. One is that the webinar will be available on YouTube almost immediately after the webinar itself, and you're all very welcome to go and re-listen to it and look at the slides. There's been so many queries about that. Second big point is I just would like to thank all of the fantastic ADI team that throughout the webinar has been in contact, and more than anything else, Jane Ciborra and Megan Anderson, who have been with us all along, guiding us through this webinar. But everybody at ADI has had some form of intervention with that. Can I remind all of you that are still with us, please do the survey of ADI on attitude to dementia. It's the most important thing that you can do this year. We're trying to get more than 70,000 replies. Please help us with that. Many of you today have already registered for our next webinar, and we hope, of course, to see a lot of you in Krakow, either in person or online. I thank my wonderful speakers for sharing their knowledge and wisdom with us. We have all learned a lot. There's been some fantastic feedback. Thank you for all of you for coming in so many and making this webinar so interesting for us all. Thank you and goodbye.